Hello, good evening, friends. I am Dr. Lalkrishna. Welcome back to my channel. And today we'll be discussing about the two thyroid cancer, that is the medullary thyroid cancer and anaplastic thyroid cancer, which will be very important for NEET PG as well as MBBS and postgraduate surgery resident and ENT residents. So without further delay, let's get started. So to begin with, medullary and anaplastic thyroid carcinoma. The first one is the anaplastic carcinoma, which we'll be discussing today. So this cancer is having very bad prognosis. So we can understand that the cancer is very aggressive and is among the least common types, is very less common and commonly seen in old age people, that is around 5 to 7 decade, 50 to 70 years of age group. And the mutation which we can see here is P53 mutation. We can see which one, P53 mutation. Then coming to how do these swellings present, like they present with rapidly enlarging swelling which are painful. So painful rapidly enlarging swelling in the thyroid region, and there can be past history of multinodular goiter also. So there will be previously thyroid swelling which has recently started to enlarge rapidly and is painful. Then it is also the uh, one having more spread. So distant metastasis here is seen in 20 to 30% cases. So these are some of the clinical features. Then what are the symptoms? Other symptoms, there could be local compressive symptoms causing hoarseness of voice due to involvement of the RLN, that is recurrent laryngeal nerve, that will cause hoarseness of voice. The voice will be affected. When there will be compression on the trachea, then there will be difficulty in breathing, dyspnea, and there will be abnormal sound production, that is stridor during breathing. So these will be the signs, symptoms when there will be trachea involvement. Then if esophagus is involved, it will cause dysphagia. And lastly, these swellings are very hard, and we have to always keep in mind that it could be a differential shell for thyroiditis, which is Riddle's thyroiditis. And these swellings can sometimes go into ulceration and necrosis. So this is the some of the clinical features and findings. Then coming to how do we diagnose these cases? Generally by the quadruple assessment, the imaging, CT, neck and MRI, but the main diagnosis is through the tissue, that is by the fine needle aspiration cytology, FNAC, which will show giant cells and multinucleated cells with heterogeneity. And if it is inconclusive, then we will go for a true cut or core cut biopsy. And we have to care that since it's a highly vascular organ, so we have to be careful, and it is not generally always preferred. So what are the some other indication for true cut biopsy? That will be Riddle's thyroiditis, lymphoma. These are some other indications for true cut when we have difficulty in diagnosis through the FNAC. Lastly, IHC, which will be helpful to rule out these cases like lymphoma, medullary thyroid carcinoma and sarcomas. We'll go for CECT, that is the 3D imaging, to look for the extent and resectability, whether the surgery is possible. In anaplastic carcinoma, the staging is same as differentiated thyroid carcinoma. Then coming to the management is almost similar to differentiated thyroid cancers. So if the tumor is restricted to thyroid or localized, then we go for aggressive surgery, that is removal of the total thyroid, that is total thyroidectomy, along with the central lymph node dissection, central neck dissection. And along with that, we go for a modified radical neck dissection. Generally it is type 3, that is functional neck dissection. And if it is spread more, then tumor is beyond the thyroid or advanced disease, we go for a palliative management. Here we'll be going for radioactive iodine is generally not used because it is of no use, because these cells do not absorb iodine. Then adjuvant radiotherapy can be given, chemotherapy in the form of doxorubicin, and targeted therapy in the form of dabrafenib and trametinib. These are useful in metaplastic and anaplastic carcinoma. These are which group of drug? These are tyrosine kinase inhibitors, dabrafenib and trametinib. Now coming to medullary thyroid cancer. So these medullary thyroid cancers arise from the parafollicular cells of the or C cells of the thyroid, and these have the function of secreting calcitonin, which can be used as a tumor marker in these cases. And these C cells arise from the ultimobranchial bodies which arise from the neural crest. So these ultimobranchial bodies arise from the neural crest. Now coming to types, it can be either sporadic, which is seen in the 4 to 6 decade and is generally unifocal, whereas familial, which is seen in MEN2 syndrome, which is most aggressive form of medullary thyroid cancer, and among them it is commonly seen in MEN2B. So MEN2B syndrome, they have the most aggressive form of medullary thyroid cancers. And these familial ones, these are seen in 2nd to 3rd decade and can be multicentric. These tumors are associated with pentagastrin stimulation, which will give rise to increased calcitonin and over turn will give rise to medullary thyroid cancers. These tumors, medullary thyroid tumors, are associated with RED proto-oncogene mutation causing this cancer. Then coming to clinical features will be here, which is thyroid swelling, which will be most common and will be associated with painful symptoms and compressive symptoms sometimes. Other than that, due to the paraneoplastic syndrome, that could be diarrhea due to serotonin, flushing due to histamine, and Cushing syndrome due to ACTH secretion. Other compound which is seen secreted by MTC is chromogranin, that is chromogranin A. So chromogranin A is also secreted by MTC, medullary thyroid cancer. Then coming to race CEA, which is seen in these medullary thyroid cancer, which is a sign of dedifferentiation and a feature of aggressiveness. So these will be more aggressive if it is raised. Then the spread, which will be generally the lymphatic or hematogenous spread, can be to the level 6 central lymph node or liver, which is the most common site in medullary thyroid cancer. Diagnosis by FNAC again, and here we'll be having amyloid rich stroma, which will help us in diagnosis. Now coming to the management is mainly surgical. If it is restricted to thyroid, we'll go for a total thyroidectomy and central leg dissection. Along with that, if we have level 6 lymph node, we'll go for a total thyroidectomy, central neck dissection, and modified radical neck dissection type 3. And if there are other nodes along with level 6, then we'll go for a prophylactic neck dissection, especially if the serum calcitonin is more than 200. So we have to be careful. Depending on the level of lymph node, we go for surgery. Just a second, sorry for the disturbance. Sorry for the disturbance. Let's continue. So here we'll not be having any role of radioiodine or iodine scan because there's no uptake. In the advanced cases, we can go for tumor debulking to improve the patient survival. Radiotherapy can be useful for local symptoms to restrict the disease. And in case of metastatic case, we will go for a vandetanib, that is tyrosine kinase inhibitor. So these cases are associated with medullary MEN syndrome. So we'll also have to rule out pheochromocytoma. And if it is present, then we have to treat pheochromocytoma first. And we also have to rule out the parathyroid disorder, that is hyperparathyroidism by serum calcium. And if that is affected and the case is having a parathyroid adenoma, then we have to treat it simultaneously along with the medullary thyroid cancer surgery. For prognosis and follow-up, we'll be going for CEA and calcitonin. And this calcitonin is one of the most sensitive marker for assessment. Then coming to the syndrome medullary, that are multiple endocrine neoplasia syndrome, MEN syndrome. So MEN1, also known as Wermer syndrome, and it is associated with mutation in the chromosome. It is associated with mutation in the chromosome 11. And the most common pituitary adenoma which is seen here is prolactinoma. Parathyroid abnormality is the most common clinical association. That will be parathyroid adenomas. Then medullary, sorry, here we will not be having medullary cancers, we will be having pancreatic cancers. So which are the pancreatic cancers? So in MEN1 we will be having gastrinoma, and overall most common pancreatic endocrine tumor will be insulinoma. Other tumors will be non-functional tumors, adrenocortical tumors, and thymic tumors. So these are some of the tumors of MEN1 or Wermer syndrome. Now coming to MEN2, here where we see the medullary thyroid cancer along with these other tumors. So MEN2, there will be again the proto-oncogene, that is red proto-oncogene. So this we have seen earlier, and the chromosome will be chromosome 10. In MEN1 it was chromosome 11. And the cancers, MEN2 is again divided into 2A and 2B. So MEN2A is also known as Sippel syndrome. MEN2A is also known as Sippel syndrome. And what are the other tumors which we have with MEN2A? That is medullary thyroid cancers, parathyroid adenoma, pheochromocytoma, and megacolon associated with Hirschsprung disease. And the mutation which is seen in MEN2A is exon 634 mutation, exon 634 mutation. Then coming to MEN2B, that is also known as Gorlin syndrome or MEN3. So MEN2B is also known as Gorlin syndrome or MEN3. Here we'll be having again medullary thyroid cancer, medulated corneal nerve fibers. So this is important, medulated corneal nerve fibers, which is different. Mucosal neuromas and Marfanoid features, Marfan syndrome features, facial features and bony features, and lastly megacolon. So megacolon, which is more common in MEN2A but is also seen in MEN2B, and the exon mutation is 918, exon mutation 918, and it will be most aggressive. Then coming to screening and management. So any patient with MEN2 syndrome will have to screen for RET mutation, especially in the first degree relatives. Then we'll go for the risk stratification. So if there is low risk, like in exon 768 mutation, we go for a prophylactic thyroidectomy at 20 years. In case of medium risk, we go for a exon with mutation 618, we go for a thyroidectomy at 5 to 6 years. And in high risk, at 1 year, like in exon 918, we go for a prophylactic thyroidectomy at 1 year. Then coming to lastly, when we go for prophylactic thyroidectomy in RET mutation carrier, when it is associated with MEN2A in less than 5 years of age, in MEN2B at 1 year of age, and in familial medullary thyroid cancers, we go for a 5 to 10 years of age. So these are some of the timings which we have to remember, which will be helpful for surgery to prevent cancers in a familial or hereditary cases of medullary thyroid cancers. So this was all about medullary thyroid cancer and anaplastic thyroid cancer. Hope it will be helpful for all NEET PG aspirants, and thank you for watching. Please like, share and subscribe. Keep studying, keep growing, never give up, because great things take time. And see you soon in next video. Thank you. Good night.